Hello everyone, my name is Sarah Nasashuri and today I will be doing my psychopharmacology case presentation on Lexapro. So let's go ahead and get started. So Lexapro is an SSRI and is therapeutic through serotonin reuptake inhibition, and it's one of the most selective SSRIs for serotonin reuptake inhibition. Half-life is 27 to 32 hours and is metabolized in the liver by the CYP450 enzymes. Use is FDA approved for major depressive disorder and generalized anxiety disorder. And off-label, it's approved for OCD, panic disorder, PTSD, and social anxiety disorder. So for this presentation, we will focus on adults with major depressive disorder. It's available in an oral solution or tablets. The starting daily dose for major depressive disorder in adults is 10 milligrams daily with a maximum of 20 milligrams per day. Common side effects can include nausea, insomnia, sexual dysfunction, sweating, somnolence. Rare side effects include QT prolongation and, most important, serotonin syndrome. So serotonin syndrome consists of tachycardia, hypertension, dizziness, elevated temperature above 38 degrees. Clinical manifestations can be nausea, vomiting, diarrhea, and mental status changes to include delirium, hallucinations, and agitation, and can have some neuromuscular signs as well, such as rigidity, hyperreflexia, tremors, and hypertonicity. So let's discuss a case in which Lexapro can be appropriate. So TA is a 22-year-old Middle Eastern female, and in short, reports anhedonia and decreased energy for the past month, not completing homework assignments, not tending to hygiene, and isolating herself. She's the source and she's reliable. Her chief complaint says, I've just been feeling depressed for the past month. I don't want to do anything, even shower, and I feel down all the time. So HPI, she reports that she's depressed and it started last month. Says she feels sad and doesn't want to do things anymore. Is showing low interest, not attending classes. Reports 4 to 5 hours of sleep with a 5-pound weight gain. She's not paying attention to conversations and denies any periods of elevated mood, denies any current thoughts of SI or SH or any past suicidal attempts, and no current medications. So she has no past psychiatric diagnosis or hospitalizations, no past medications, no illicit drug use or marijuana use, just drinks alcohol monthly on average and never more than 3 drinks, denies any past medical history or seizures or TBI, denies any allergies. Family history reports mother is anxious but not formally diagnosed. Father has no history but drinks alcohol weekly. Sister has ADHD at 8 years old and is taking Vyvanse, but no known family history of depression. She reports normal growth and development. She is a high school graduate, is a full-time student. She lives in an apartment with a roommate, no guns in the home, single and heterosexual, and agnostic. Diagnostic tests we did are the C-SSRS, which puts her at minimal risk for suicide, the PHQ-9, which she scored high, 19, which puts her at moderately severe depression. Mental status exam is significant for psychomotor retardation, low rate speech and low volume, depressed mood with restricted affect and poor concentration. She has a logical thought process with no SI, HI, or AVH, with good insight. Assets include having a supportive family, secure housing, and good judgment. Liabilities are decreased energy and motivation, and no significant physical exam findings. So moving on to differential diagnoses, we have adjustment disorder, generalized anxiety disorder, and unspecified mood affective disorder. But the main diagnosis will be major depressive disorder, single episode, unspecified, and is due to meeting that criteria for more than 2 weeks. Pharmacology, we're going to start her on Lexapro, 10 milligrams by mouth daily for major depressive disorder. No lab work is required, but it would be wise to get some blood work to rule out medical causes for depression. Non-pharmacological could be CBT therapy and educating her on some positive coping skills. And some patient education, we tell her that it may take up to 2 to 3 weeks to take effect, and that nausea and jitteriness are expected. You can take it with food. And we'll educate her on the side effects of serotonin syndrome, educate her on the timeline and the side effects she'll experience, and to stop taking the medication and visit the ER if that does develop. And we'll follow up in 2 to 4 weeks. Referrals would be to LMFT for therapy and primary care to rule out medical causes. So in this case, Lexapro is appropriate because it's the first-line medication, there's no contraindications, and the risks outweigh the benefits. Some barriers, like we mentioned, would be taking the medication daily at the proper dosage, and maybe some fear regarding starting a psychiatric medication. Some cultural considerations is regarding to the stigma in Middle Eastern communities towards mental health, and the family may not approve of psychiatric medications. Now let's discuss a case in which Lexapro would be inappropriate. So now we have J.A., who's a 61-year-old Middle Eastern male, and he's been experiencing a depressed mood, difficulty sleeping, and a loss of interest in daily activities for the past 2 months. He's the source and he's reliable. He says, I've been feeling down for a while, I don't want to eat and I can't sleep. It's hard to move forward. His HPI is that he's had a depressed mood and anhedonia the past 2 months with poor sleep. He says the Parkinson's is difficult to manage and he feels isolated from his family and friends. He used to enjoy walking on the beach and now he endorses fatigue with decreased concentration. Says he feels guilty that his wife is his caretaker. His current medications for Parkinson's are carbidopa, levodopa, and rasagiline, and metoprolol for hypertension. He denies any past psychiatric history or hospitalizations, no past psych meds, but he is taking a Maui for Parkinson's, no illicit drug or cannabis use, and after Parkinson's, he's been sober from alcohol for 5 years. Medical history, he has Parkinson's disease and hypertension. No known drug allergies, and family history is significant for sister having depression at age 40 and is currently taking Zoloft 50 milligrams daily. Social history, he's married with 2 children and lives in a house with no gun. He's no longer driving due to his Parkinson's. He used to be a police officer for 30 years, but he retired after his diagnosis, and his wife is his primary caretaker. Diagnostic tests, he scored 12 for PHQ-9, which puts him at moderate depression and minimal risk on the CSSRS. Mental status exam is significant for his unsteady shuffling gait, psychomotor retardation, resting tremor, low speech rate. He's ANO times 4. Sad mood with restricted affect, no SI, HI, AVH, and has a short attention span and concentration with fair insight. Assets are that he's seeking treatment voluntarily, stable home, support system. Liabilities are that he can't drive, needs reminders for meds, and he's a fall risk. Physical exam findings were significant for neuro, which is moderately intact, but has a positive resting and action tremor. So differential diagnoses are going to be similar, and the one diagnosis is major depressive disorder, single episode unspecified due to meeting that criteria, and Parkinson's disease without dyskinesia. So pharmacology, we're going to continue the medications that he's been taking, and SSRI is contraindicated because of the Maui. We can consider doing trazodone, but again, no lab work required, maybe to rule out medical causes. Non-pharmacological interventions can include CBT therapy, educating on some coping skills. Patient education could be proper sleep hygiene and to promote independence in EDLs. Some referrals could be to coordinate with a neurologist to assess if we can wash out the Maui and start an SSRI, refer to PT and OT, refer to LMFT, and refer to primary care to rule out medical causes. So why is this inappropriate? So Lexapro is contraindicated with concurrent Maui use, which causes increased serotonin syndrome risk, so it's not a good choice. The patient's age can cause increased risk of side effects or safety issues such as falls, and at this time, the risks do not outweigh the benefits. We can put him at cognitive behavioral therapy or try a Maui washout if needed. So again, the barriers, concurrent Maui use. The PHQ-9 is moderate, so we can do CBT first line prior to medications, and we need interdisciplinary team communication to manage his Parkinson's. Similar cultural considerations regarding the stigma in Middle Eastern communities, and the wife might not approve of taking psychiatric medications. So what was learned from this? So we learned that although Lexapro is a first-line medication for depression, not everyone can benefit. And we need a complete list of all medications to reduce the risk of serotonin syndrome, and that adverse effects are common. Patient education and cultural consideration is important because it can promote medication compliance and foster trust. It can also aid in identifying potential barriers to not taking medication. And not all depression needs to be treated with psychiatric medication. Mild to moderate cases of depression can benefit from other interventions such as cognitive behavioral therapy initially. Here are my references, and I thank you so much for listening to this presentation.